So this is the second in the series of haematology podcasts, and it's going to be on the disorders of haemostasis. I'm going to divide this into three sections. The first section, I'm going to really look at some of the crucial physiology you need to know to understand haemostasis, as well as some of the investigations that we need to know about. Then I'm going to consider in the second part the disorders of bleeding, and in the third part, disorders of thrombosis. And at the end, I'm just going to kind of add on a little bit of information about anticoagulant treatments and how you institute them, follow them up, and etc. So in the first part of this podcast, I'm just going to consider some of the most basic physiology that's needed to understand disorders of hemostasis. I mean, I don't think it's necessary to actually learn the entire coagulation cascade, but it is necessary to kind of understand it from a very basic point of view. So to this end, I'm just going to kind of go through the normal hemostatic mechanism. So first of all, I think it's important to distinguish between hemostasis, which is a normal physiological process, and thrombosis, which represents a pathological process. So normal hemostasis really consists of four important bits. So there is primarily vasoconstriction, which is a reflex response to injury of the vessel wall. Then there's platelet adhesion and activation, usually because the extracellular matrix underneath the endothelium has been exposed. This results in the formation of a primary or temporary hemostatic plug, which is also called a loose platelet plug. So in the next bit, we have stabilization with a fibrin-rich scaffold or formation of a clot or secondary hemostatic plug. Now this happens because of the activation of the coagulation cascade, usually driven by tissue factor, and stimulating a series of cascades that ultimately result in thrombin generation and the conversion of the soluble fibrinogen into the insoluble fibrin. The last stage is very important because it prevents an explosion of clotting within the blood, which obviously would be bad news. And this is largely mediated by TPA, tissue plasminogen activator, which catalyzes the breakdown of plasminogen into plasmin. And plasmin is responsible for breaking down fibrinogen and fibrin and all these things into their various products, which are collectively called the fibrin degradation products. There's also quite a lot of containment done by other anticoagulant factors, such as antithrombin, protein C, and protein S. So those are the kind of basic principles. Now specifically, if we look at the coagulation cascade, this can be divided up into a common pathway and two pathways that activate this common pathway, the intrinsic and the extrinsic. The common pathway is the most important one to look at, and we've pretty much already discussed it. Basically, this common pathway leads to the formation of soluble fibrin that really stabilizes the primary hemostatic plug that's been formed by the platelets. Now, there are a sequence of steps that are important here. Basically, factors 10 and 5 from either the intrinsic system or the extrinsic system cause, with the help of phospholipids and calcium, prothrombin, or factor 2, to be turned into thrombin, or factor 2A. And this primarily catalyzes the breakdown of fibrinogen. As we've said, the pathways leading to this are intrinsic and extrinsic, and each of these has specific factors associated with them, and this is reflected in how specific deficiencies of factors affect the tests that we use to look at these two pathways. So in the intrinsic pathway, the fairly unique factors are most importantly 9 and 8, which of course deficiencies we see in haemophilia A and B, but also includes 11 and 12. In the extrinsic system, the most important thing is tissue factor or tissue thromboplastin, which really starts off the whole cascade when the blood is exposed to subendothelial extracellular matrix. But the only other really unique factor here is factor 7. And I think that's pretty much all that's necessary to know to really understand this cascade and how it affects diseases. So the next important thing is to kind of correlate that with how clinically we investigate these clotting and platelet problems. The first line test that's usually employed when we think there may be a problem like this is the full blood count. And this is really useful because it allows us to have a look at the platelets, which, if altered, can give us a clue that this might be a platelet problem. And it also allows us to look for other abnormalities of bone marrow origin, such as anemia or leukopenia. The next thing we want to do is a coagulation screen. Now, there are really three very important tests here. And the first one is the prothrombin time, that's typically expressed as the INR. Now, this looks at extrinsic and common pathways. And the most important thing to remember there is it's not just the extrinsic pathway. I seem to see on quite a lot of the kind of cascades where these things are labelled that it just seems to appear next to the extrinsic pathway, but it will also be affected in all the different disorders that affect common pathway components as well. The next is the activated partial thromboplastin time, or APTT, which looks exclusively at the intrinsic pathway and is, as we'd expect, therefore elevated in conditions affecting factors that are exclusive to this pathway, such as in haemophilia factor 8 and 9. The last important one is the thrombin time, or TT, which tends to be increased if there is a reduced fibrinogen level, or if fibrinogen polymerization is inhibited by fibrin degradation products, as may occur, for example, in DIC. Importantly, however, here also an elevated thrombin time, TT, can be caused by heparin as well, which majorly inhibits thrombin. There's one more test that probably is quite important, first line, and that is the factor 8 and von Willebrand factor activity, which can be measured via various antigen assays. This is important because von Willebrand's disease often, or quite a lot of the time, can cause no disturbance in the above tests. So this allows more kind of definitive diagnosis to be made. So that pretty much completes all I wanted to say about the basic mechanisms of haemostasis and how we look at them clinically. I'm now going to talk about the pathologies that affect the hemostatic system. Now, the first thing to do is to divide them up. There are two broad conditions. There are those that cause hemorrhage, or the other group of disorders are those characterized by thrombosis, and these are thrombotic disorders. So I'm going to look at each of these in turn. So firstly, bleeding disorders, which we can really split up into disorders due to problems with platelets, whether that's the number of them or the function of them, or due to problems with the coagulation cascade. So platelets first. The normal platelet count is between 150 and 400 times 10 to the 9 cells per litre, but may drop quite considerably before any symptoms are experienced by the patient. And the crucial figures here are that most patients are asymptomatic until the platelet count drops less than 50, when they start to get petechiae, which are very specific for platelet disorders, or ecchymoses, which are more kind of widespread petechiae, which are less specific. But if the platelet count drops further to less than 20, there tend to be spontaneous mucocutaneous bleeds. So in the stomach, they could cause hematemesis, in the gut cause melena, or in the kidneys with hematuria. There are two basic kind of pathogenic mechanisms that can cause disorders of platelets, and these are either things that decrease their number, or thrombocytopenia, and those that affect their function. I'm really going to concentrate mostly on those that affect number, or different causes of thrombocytopenia. But just to mention very briefly platelet function, defects in platelet function can be acquired or inherited. The acquired ones can be fairly common, such as with drug use, for example aspirin or uremia. Inherited ones are really quite rare and include glycoprotein 1b deficiency, or Bernard-Soulier disease, glycoprotein 2b3a deficiency, Glanzmann's thrombocythemia, and storage pool diseases. But what I think is more important is disorders of platelets caused by number, or thrombocytopenia. Thrombocytopenia can occur for two reasons. Either there is decreased production from the bone marrow, as would occur, for example, in various leukemias and multiple myeloma. And in this, you would find other features of marrow infiltration, such as anemia or leukopenia. More commonly, thrombocytopenia is actually due to increased consumption of platelets, which may be either immune-mediated or non-immune-mediated. The most common immune-mediated cause is immune thrombocytopenic purpura, which typically causes an isolated thrombocytopenia on a blood film. And this is because antibodies are formed against antigens on the platelet surface, and these have resulted in platelets being removed by the spleen. There are two distinct syndromes that occur. In acute ITP, in children, usually between the ages of 2 and 6, there is a prodromal viral infection of some sort, so either an upper respiratory tract or a diarrheal illness, followed by sudden onset of symptomatic thrombocytopenia. This is reversible and really requires little intervention, obviously apart from monitoring. Chronic ITP is more common in more old people, so middle-aged women typically, who've had no preceding infection, and spontaneous remission in these people is usually quite rare, and their management usually requires steroids, and in most severe cases where there's massive enlargement of the spleen, splenectomy, and sometimes treatment with IVIG. The next important cause of immune-mediated thrombocytopenia is that caused by drugs. And drugs that have been implicated include penicillin, thiazides, oral hypoglycemics, heparin, and though not technically a drug, transfusion can also result in this phenomenon. There were two other very important causes of an isolated thrombocytopenia. These are SLE, which may actually present in this way, and latent HIV. So these, of course, should both probably be excluded before considering a diagnosis of ITP, even though this is most common. Non-immune mediated thrombocytopenia is less common and can be caused either by DIC, disseminated intravascular coagulation, or one of the microangiopathic hemolytic anemias such as hemolytic uremic syndrome or thrombotic thrombocytopenic purpura. Next, I'm going to look at the disorders of coagulation, which can cause these bleeding problems. And the best way to think about these are those that can be inherited ones, such as haemophilia and von Willebrand's disease, and those that are acquired, for example, in individuals with liver disease or vitamin K deficiency. Compared to problems with platelets, disorders of coagulation typically present with hemarthroses and deep muscle hematomas, as well as with delayed bleeding after surgery or trauma, which may actually be up to 1 to 2 days after the insult. So first of all, the inherited disorders of coagulation. There are two really important ones to consider. First of all, haemophilia A and B. This is due to congenital deficiency of either factor 8, which is haemophilia A, or factor 9, which is haemophilia B. It's an X-linked recessive disorder, and A is considerably more common than B. The clinical presentation is identical between the two because factor 8 and 9 actually form a complex that's required to activate factor 10 and subsequent common pathway coagulation. However, the severity of the disease typically depends on the factor level, and it's said that with less than 1% factor level, there's spontaneous bleeding, as we said, into joints and large muscles, causing hemarthroses and hematomas. Between 1 and 5%, there's more moderate disease with bleeding following mild injury and operative procedures, and greater than 5% really is quite mild disease. As factor 8 and 9 are in the intrinsic pathway, there is a prolonged activated partial thromboplastin time, but a normal PT. Management requires lifelong replacement with freeze-dried factor concentrates. Von Willebrand disease, which is the second important inherited disorder of coagulation, is inherited in an autosomal dominant fashion and can cause either a problem with the number or amount of von Willebrand factor produced, or so-called type 1 disease, which is a partial deficiency, typically presenting in adult life, can be due to the quality of the factor itself, which is type 2 disease, or maybe in its most severe form, type 3, which is the rarest, luckily, total quantitative deficiency of von Willebrand factor, often with associated severe factor 8 deficiency. The clinical presentation of this disorder can be figured out by knowing that von Willebrand factor is important in initiating the primary hemostatic plug, so the binding of platelets to subendothelial extracellular matrix, but is also important for stabilization of factor 8. So in most individuals, von Willebrand's disease will present the same as with platelet disorders, so with petechiae, ecchymoses, mucocutaneous bleeding. However, in the most severe forms, the factor VIII pathway will be defected. So there will be a clotting-like pattern seen as well, and a clotting-like pattern of presentation. Diagnostically, coagulation tests may not be altered at all, but may have a increased APTT and PT together. Treatment is with desmopressin, which can increase secretion from the endothelium of von Willebrand factor by up to 10 times, and this is particularly useful in partial deficiency or type 1 disease. In more severe disease, it may be necessary to use either cryoprecipitate or factor VIII concentrates. So the next subseries is the acquired disorders of clotting. And the first one I'm going to talk about a little is vitamin K deficiency. Vitamin K is required for carboxylation of coagulation factors 2, 7, 9, and 10. And therefore, as this includes both intrinsic factors and extrinsic factors, as well as common factors, we typically see a raised PT and a raised APTT with this condition. Causes include malnutrition and malabsorption, and importantly, warfarin therapy, as warfarin is a vitamin K antagonist. The treatment is obviously vitamin K. The next problem, or acquired problem I want to talk about, is liver disease, which causes its problems with clotting because basically the clotting factors are not being produced. However, interestingly, liver disease also can exacerbate the clotting problem by adding a platelet problem, due to pooling of platelets in an enlarged spleen due to portal hypertension. Like with vitamin K deficiency, liver disease affects all of the pathways, so there's a prolonged PT and a prolonged APTT. The last acquired problem I want to talk about is disseminated intravascular coagulation, which is really not a diagnosis but a phenomenon, typically due to an underlying disorder which causes widespread endothelial damage. Causes include disseminated gram-negative sepsis, traumatic events such as amniotic fluid embolus, placental abruption, mismatched blood transfusions, and end-stage malignancy. Basically, there is a systemic activation of clotting with intravascular deposition of fibrin and eventually depletion of platelets and coagulation factors. Therefore, this is both a clotting problem causing thrombosis and a bleeding problem as well, causing hemorrhage. It therefore causes an elevated PT, an elevated APTT, an elevated TT because of the excess production of fibrin degradation products and the reduced levels and due to consumption of fibrinogen. And often, just like in DVT, these patients have a positive D-dimer, as a D-dimer is one of these degradation products. Treatment is really supportive with heparin, platelets, and other therapies with the aim to really buy time to treat the underlying disorder that's causing it. So that really completes the important points about disorders of bleeding. I'm now going to go on, and this is a little bit shorter, to talk about the thrombotic disorders. Now, thrombosis is a pathological clot formation which can occur either in the arterial system or the venous system. In the arterial system, it's typically due to some change in the vessel wall, for example, an atherosclerotic plaque, while in the venous system, it's usually caused by stasis or some subtle change in the coagulability of the blood. I'm not going to talk about arterial here, but mainly venous. So, just like when we were talking about disorders of coagulation, we can divide causes of venous thrombosis into those that are inherited and those that are acquired. So inherited causes we describe as basically thrombophilia, where there is a predisposition to form clots. Usually these are recurrent DVTs, pulmonary embolisms, or clots in unusual sites, such as axillary vein or the cerebral veins. It's important to note here that these clots may go totally unnoticed. For example, DVTs are typically asymptomatic in up to 50% of patients. Now, what usually happens is that as long as these patients are fairly normal, they kind of go on and they're absolutely fine. But as soon as an additional pro-clotting factor is introduced, such as the pregnancy or long periods of immobility on a plane or combined oral contraceptives, this kind of pushes them over the metaphorical edge of the cliff, and they fall off and develop one of these clots. And there are 5 important types two of which are actually most important, and these are the procoagulant mutations. So factor V Leiden, which may be found in up to 10% of people, is a point mutation in factor V, which leads to normal procoagulant activity, but an altered response to inhibition by anticoagulant factors. The next problem is the prothrombin G2021-0A mutation, which is present in up to 5% of people and is associated with particularly elevated levels of prothrombin and therefore a procoagulant state. The deficiencies are relatively rare and are all deficiencies of the anticoagulant factors such as protein C, protein S, and antithrombin. So now a little bit about some of the acquired causes of venous thrombosis. Top of the list probably is immobility. Immobility is very common in hospital patients, elderly patients who are unable to move around, patients after surgery, etc., etc. Basically, the problem here is one of stasis, where there is local accumulation of the clotting factors in the platelets, which may lead to the formation of a clot. However, there is also typically other problems that occur in these patients, such as surgery. And in surgery, the tissue trauma can lead to a procoagulant kind of inflammatory-like response with increased output of fibrinogen and platelets. And this also predisposes or increases the risk of thrombosis. Interestingly, the risk is highest with orthopedic procedures of the hip and knee or gynecological surgery. In malignancy, while there usually can be immobility or surgery occurring, there's a specific kind of procoagulant molecule that may be present on tumour cells that can lead to an increased disposition to clot. And it's interesting that in individuals who've had an idiopathic thrombosis, 10% of them will have malignancy diagnosed within 12 months of their event. It's also interesting that certain tumours can cause certain collections of clots. For example, adenocarcinomas are associated with non-bacterial thrombotic endocarditis. There are kind of three other important acquired causes. These are antiphospholipid syndrome, where via an unknown mechanism, circulating antiphospholipid antibodies bind to platelets and endothelial cells and cause aggregation. This tends to be present in young to middle-aged females, and they typically have a triad of recurrent DVT-PE, stroke, and miscarriage. The next is a hyperestrogenic state, so for example pregnancy or in ladies taking combined oral contraceptive. And the basic problem here is increased hepatic synthesis of coagulant factors and reduced synthesis of antithrombin 3 factors. The last thing, and rather paradoxical phenomenon, is that of heparin-induced thrombocytopenia causing a thrombotic disorder, not a bleeding disorder as you would usually expect of thrombocytopenia. Basically, the problem here is that unfractionated heparin can induce circulating antibodies, which can lead, rather than to destruction of platelets, to their activation, and also to activation of endothelial cells, which, as we've already spoken about, can cause thrombosis. So lastly, for this podcast on disorders of haemostasis, I'm going to look at anticoagulant therapy, as this is obviously a very important topic in clinical practice. So basically, anticoagulant therapy is usually provided for both treatment and prevention of thrombosis. And the important point here is that for an isolated calf DVT, 35% of people will have extension of their DVT proximally if untreated. However, this drops to 0% if they are treated. So clearly there's a rationale for using this therapy. And that even though there are newer preparations such as heparin, pentasaccharide, and hiridin, the two major drugs that I'm going to talk about are heparin and warfarin. So heparin is a drug that has an immediate anticoagulant effect by potentiating the action of antithrombin 3. Importantly, it's very safe in pregnancy. There are really two flavours to this. Unfractionated heparin, which is given as an IV bolus and then an infusion, and low molecular weight heparin, which can be given once daily subcutaneous injection, which is now really favoured. Heparin therapy can be monitored by looking at the activated partial thromboplastin time, and you're looking for one between 1.5 and 2.5. However, with low molecular weight heparin, because of the very reliable pharmacokinetics of this drug, monitoring is not usually required, but if needed may be done using an anti-factor Xa assay. It's also probably important to know that the effect of heparin can be reversed with protamine. Warfarin is a long-term anticoagulant therapy, and the drug itself is a vitamin K antagonist, which typically takes a number of days to start working because it's influencing production of the various factors, so they need to go through their half-lives and degrade. Monitoring is really essential with warfarin therapy because of the numerous interactions that it has, and it has fairly unstable pharmacokinetics. And this is done by looking at the PT that's usually expressed as the INR. Now, for normal people, for example, people with problems with their heart, atrial fibrillation, you want to have an INR between 2 and 3. If there are valves that have been replaced or there are recurrent problems with clotting, you want to aim for one slightly higher, so maybe between 2.5 and 3.5.